Georgina, I am now speaking. I think that's my cue. Good morning, everyone. I'm Professor Chris Harnish at Thomas Jefferson University and the Malawi Health and Design Collaborative. Welcome to the Implementation Learning Seminar Series. We are happy to have you here. The aim of this series is to encourage collaborative learning for the advancement of small and sick newborn care. This is one of the series built around the health systems building blocks. You can find more information at each of the links on this slide. And this is the 7th HSBB learning series. This one focused on infrastructure. So we're really happy to have everyone here today, and let's get started. Yeah, as mentioned, this is an infrastructure series that's focused on newborn care unit design, space, flow, and floor plans. And as an introduction, I'm Chris Harnish, and with us today are a couple other panelists. If they'd like to introduce themselves.
Good morning and good afternoon, everyone. My name is Stephen Luna-Muse, and I'm a senior project manager with the Institute for Healthcare Improvement based near Boston. Good to be with you all.
And Dr. Bundala? We'll have Dr. Bundala introduce when we get to that point. So Stephen, without any further ado, would you like to start?
Sure, thank you very much, Chris. Hello again, everyone. So happy to be here. We're honored to be invited by Nest 360 to present to you all. We've only got about 10 minutes to share our presentation, so there's a lot to go over, but we are more than happy to share materials with you all after the fact so you can dig deeper about what we are presenting. And we're happy to answer any questions you may have and follow up as needed. So our project is designing maternal and newborn spaces for quality of care. This is a project co-funded by the Bill and Melinda Gates Foundation and the Elsa and Peter Soderberg Charitable Foundation. It launched a couple of years ago at the end of 2020. The planning phase did at least, but for the pandemic reasons, implementation didn't really begin until the middle of 2021, but we are looking to wrap everything up by the end of this coming year. And we're happy to share with you all what we've learned so far. So please go ahead, Nita. The aim of our project was to assess the content of ideal maternal and newborn care from the user perspective, taking into consideration the local context. And I'll show you in a minute, this project is implemented in both Ethiopia and in Bangladesh. We wanted to understand how the design of healthcare facilities, specifically maternal and newborn care spaces, how they affect the quality of care delivered to mothers during and around their pregnancy and delivery phase, and then learn if and how the experiences of care differ across contexts between Ethiopia and Bangladesh, and then try to extrapolate from there. Nita, go ahead. So in Ethiopia, we worked very closely with the Ministry of Health, who we have a very strong relationship with, to select some participating facilities to focus on. And so with their consent, we did our study in Melkawar Health Center and Muhammad Akhlid General Hospital in the Afar region, and in Yifag Health Center and Atazemen Primary Hospital in the Amhara region. So in Ethiopia, we're working very closely with the ministry, along with our global partner, Mass Design Group, and a local architecture firm called Fassa Georgis Consult. And on the next slide, we can see in Bangladesh, we are also working very closely with the Ministry of Health and Family Welfare, and with their guidance, we selected 2 Upazila health complexes, primary care facilities, and then 2 general hospitals in Munchiganj district, which is near the capital Dhaka, and in the Jashore district in the western part of the country. And so there again, we're working with the ministry, we're working with Mass Design as our global partner, and we're working with the local firm ICDDRB as our architectural partner in Bangladesh. Next slide. So our project aims to accomplish two things. So we are working very intentionally for the benefit of our Ethiopian and Bangladesh partners. And we are also trying to extrapolate out and to produce something that can be applicable globally. So in Ethiopia and Bangladesh, we are working with these specific facilities that I highlighted, and we are trying to come up with designs so that the policymakers in either country can decide to construct or reconstruct healthcare facilities, specifically the maternal and child care spaces, to improve the quality of maternal and child care delivered in those facilities. And then if those facilities are constructed, we hope that that will lead to improvements in the delivery and quality of care. And then on the global stage, we are turning everything that we learned through this project into a set of what we're calling global goods. And it will be sharing our general learnings from our efforts, as well as producing a set of tools so that anyone in the world will be able to replicate what we've been able to do in their local context to redesign healthcare facilities from a user perspective. Next slide. So to begin this process, we did a literature review just to learn about how folks have gone about the design of healthcare facilities in the past, how they've thought about the impact of a facility design on the quality of care. But then after that literature review, we dove into data gathering. And so through a series of interviews, quantitative surveys, focus groups, design sessions, we engaged dozens of mothers, their companions, their family members, community members, and frontline providers in the various facilities within the two countries to learn about their experience receiving care and delivering care in their facilities, and asking them specifically about how the facility design influenced their experience of that care. Next slide. So our overarching learning question for this project was, how does the physical design of a maternal care facility influence and impact the experience and quality of care provided in that space? And on the next slide, we can see we sort of distilled all of our learnings into a set of categories, essentially. And again, I'm going to share links to some much deeper documents where you can learn much more about how we went about this and the specific learnings in each facility, in each country, and how they differ. But overall, space was, of course, the first thing that we really drilled down on. And in Ethiopia, in the 4 facilities that we engaged, we found that there is somewhat a lack of space to deliver quality of care in these facilities. But overall, there's actually just a lot of underutilized or unused space in the facilities that we engaged. And so in Ethiopia, we focused on trying to reorganize and reorient spaces to create better flow between them, and therefore hopefully a better delivery and experience of care. In Bangladesh, there's been a lot of population increase in the two communities where we engaged our facilities. And so there we are seeing a severe lack of overall space. And so our intervention in Bangladesh has been primarily trying to create new spaces to deliver this maternal and neonatal care. Next slide. In both countries, we saw that women were leaving the facilities very soon after delivery, even within just a matter of hours. And of course, you all know this is not news to anyone, but that means they are missing out on critical postnatal care, both for the mother and for the infant. And so we are trying to understand why they're leaving in order to create opportunities for them to stay longer. And so through our interviews, our focus groups, our surveys, we learned that mothers are citing crowding within the facilities, discomfort, a lack of sanitation in the facilities. These are the reasons why they are citing what they want to leave. And so again, in our redesign process, we're trying to create more private spaces, more sanitary spaces, so that they are encouraged to stay longer and receive the essential postnatal care. Next slide. This is not a surprise to anyone, certainly wasn't a surprise to us, but it was really important to get it reinforced with primary data. Companions are absolutely essential to the birth journey, from arrival to labor, to delivery, to postnatal care, to leaving the facility. Companions are absolutely critical to a mother's experience. They serve as proxies, they serve as emotional support, physical support. They carry the mother's belongings. They can serve as translators as needed. They will alert providers if a mother is experiencing an emergency of some kind and the provider isn't around. Companions are an essential part of this process, but in none of the facilities that we engaged was there space created for companions to be part of the process. And so again, in our redesign process, we are creating intentional specific spaces so that companions can be part of this process from beginning to end. Next slide. Safety is one of the things, of course, that we tried to assess in our engagement. In Ethiopia, we found that nurse and provider spaces, or their stations rather, were not situated properly within the facilities so that the providers didn't always have access to the patients that they were supposed to be monitoring. They were sometimes removed from their patients, which of course can be a danger if a patient goes into some sort of emergency situation. And so in Ethiopia, our part of our redesign has been to resituate those nurse and provider stations so that they are as centrally located as possible so that they can always have audio and visual access to the patients in their care. In Bangladesh, we were very pleased to see that those stations actually are fairly well situated. They have consistent access to the patients that they're monitoring. And so in Bangladesh, the safety focus has been more on creating adequate lighting on the exterior, making sure that there's full-time security in these facilities, especially since patients can arrive throughout the night when it's dark. So we want to make sure that they feel safe when they're arriving, no matter when they arrive. Next slide. So the next couple of slides are very much related, mobility, and the next one is birth position. We found, again, no surprise to anyone on this call, I'm sure, that women want to be able to move around during labor. It's an essential component of creating comfort, mobility, but they cited that in all of these facilities, there is no dedicated spaces for them to be able to move around. They feel that they are crowded, they feel it's not private enough, there are not grab bars necessarily, so they can't safely move around either. And so again, in both spaces, even though women want to be able to move around and even providers encourage them to be able to move around at their ease, they're not able to. So in our redesign process, we are focusing on creating dedicated private spaces for women to be able to move around during labor, creating grab bars so they can move around safely. And on the next slide, birth position, very similar. Women want to be able to try alternative birth positions during delivery. But the facilities at the moment are not designed to enable that. The delivery rooms are crowded. They're not adequately equipped with the right equipment for women to be able to try certain birth positions. And so in our redesigns, we are trying to create the proper conditions so that women can try whatever position feels right to them during the delivery process. Next slide. Again, not a surprise to anyone, I'm sure, but religious and cultural practices came up as a very strong component for mothers and companions. They want to be able to complete particular cultural and religious practices throughout the birth process, during arrival, during labor, post-delivery. They want to be able to complete these things. But again, the facilities that we engaged, there are no spaces created for these things to be completed. And this is one of the reasons why women and their companions cited leaving the facilities so soon after birth. They want to be able to go home so that they can complete these practices. So in our redesign process, we are trying to create these intentional specific spaces for women and companions to be able to complete whatever ceremonies, practices they want to be able to, so that they are willing to arrive sooner and stay longer within the facilities and therefore receive the care they're supposed to receive. Next slide. Sanitation. This was across the board a major problem cited by all parties, by the mothers, their companions, the providers, administrators, the Ministry of Health folks that we engaged. Everyone recognizes that sanitation in these facilities is completely inadequate. There's not enough running water, there were not enough bathrooms, there's just not enough space created for these. And so within our abilities, we are trying to, again, create as much space as we can for proper sanitation. We're creating additional toilet facilities, creating space for laundry facilities, things like that. We're creating rainwater collection systems. And so these are relatively short-term interventions that we are hoping will be built and therefore will improve the sanitation conditions. But we're in ongoing talks with the ministry about how to solve this long-term issue, how to get potable water continuously available within these facilities. So we're doing our best in our designs, but certainly recognize that there are much more long-term interventions that we need to explore. Next slide. And finally, staffing. Of course, you can't have quality delivery of care without proper staffing. And in Ethiopia, we found actually that there is an adequate number of nurses, doctors, midwives, other providers to the number of patients that they see in the specific facilities that we engaged. So we're very happy about that. In Bangladesh, unfortunately, due to that rapid population increase that I mentioned earlier, there is not enough space for all the patients that need to be seen, but there also are not enough providers for the number of patients who are seeking care these days. And so we are working with the ministry to put together a plan for how to increase staffing ratios so that if and when the facilities are rebuilt or reconstructed, they can be staffed appropriately to deliver quality care. Next slide. Again, my time is coming to an end here, and I will happily send all these slides and happy to answer questions. But just to give you an overview, in Ethiopia, we have completed our data gathering immersion process, learning from the communities, from the providers, from the mothers. We've put together a whole set of concept designs for the 8 facilities that we engaged, the 4 in Ethiopia and 4 in Bangladesh. And we are working with our architectural partners now, Mass Design Group, our global partner, Fasa Georgis Consult in Ethiopia, and ICDDRB in Bangladesh to create a set of actual construction documents that we can hand these over to the ministry in hopes that they will be actually taken forward and constructed. And we're in that process right now. And along with that, we are putting together costing estimates for all the facilities that we've designed so that the ministry and potential funders have a sense of what it would take to turn these designs into reality. And you can see on the right side of the screen there, this is a screenshot of one of our designs for one of the primary facilities, UFOG Health Center. And on the next slide, you can see a similar thing for Bangladesh, so Rajdakan Upazila Health Complex. This is just a screenshot of one of our concept designs for that facility. And the next slide, I think, yes, global goods, just to finish off. So I mentioned earlier that not only are we working on designing facilities for these specific contexts and these specific countries, but we want to turn everything that we've learned and everything we've put together into what we are calling global goods so that anyone in the world can replicate our process. So these are in the design phase right now. They should be published in the next couple of months, and they will be publicly, globally applicable or accessible. We'll happily share it with all of you. I'll let you know through forums like this webinar that they're available and how to access them. But they're going to consist of 3 main components. There will be an introduction or context setting where we really get folks excited about the built environment and how that relates to quality of care and specifically maternal and neonatal care provision. That'll involve a really snazzy video that we're putting together. Looking forward to sharing that with you all. There will be a facility design guide, or what we're calling a facility design guide. These will be a step-by-step set of instructions and tools so that, again, anyone in the world, regardless of whether they're part of the government, a private funder, an implementer, a community advocate, can take what we have done in these 8 facilities in these 2 countries and replicate it in their own local context. And then finally, a set of design principles. This will be sort of like a cheat sheet. If you can't afford the investment of time and resources to go through a full engagement design process with the facility design guide, this design principle document will be a set of what we have found to be relatively generally applicable learnings about how facilities should be designed, the components that should be considered, specifics about how beds should be oriented, whether there should be a sink in this room versus that room, which rooms should be situated next to each other, things like that. So that, again, if you can't go through a full engagement process to completely contextualize for your environment, these are pretty applicable learnings from our engagements that should be relatively relevant to anywhere in the world. And with that, I think my time is up, and I will say thank you all. I'll stick around, happy to answer questions. And again, happy to share links to all of our learnings and designs after the fact so that anyone can dig deeper. And we're happy to follow up with anyone who's interested. Thank you all. Oh, Chris, I think you're on mute.
Yep, much appreciated, and I'm excited to follow you. I think we found some fairly similar conditions and existing contexts in Malawi as well. So let's get started. And yeah, me too. These first sections we can move through pretty quickly. So I hope you're ready to go. As a professor of architecture at Thomas Jefferson University, I also run the Malawi Health and Design Collaborative that catalyzes health and design professionals and strengthens public healthcare systems. Next. And we believe there's a symbiotic relationship between architecture and urban design, health infrastructure, and public health, where health-centered research methods can inform spatial design strategies, and design and geospatial designs are social indicators of health and healing. Next. Ultimately leading to the thesis that every building is a public health intervention. Next. So in order to achieve those goals, we use evidence-based design metrics that I'll skip past. Next. And we've been working in Malawi since 2014 on a slow build through specific district level hospitals. And then with the Malawi Department of Buildings, the biggest hospitals in the country, Kamuzu Central and Queen Elizabeth Central. And we have partnerships with the Ministry of Health that really led to the focus on this project. Next. Some of the work we've done includes geospatial analysis of entire medical campuses. Next. Focus on open wards in particular, and I think there's quite a bit of overlap with what Stephen was discussing with regard to open wards, staff efficiency, patient privacy and dignity, and guardian and family member participation. Next. And Stephen, as you were saying, I think the notion of the guardian and family member are one of the key components that are unique to these health infrastructure settings. So we've been working on different modules of open wards that will still maintain staff efficiency, but will also include increased privacy and dignity for patients, as well as space for guardians and people's belongings, which we know are so critical in these settings. Next. We also have worked specifically on infectious disease units and the design of infectious disease unit facilities in these settings, research with both care providers and patients. Next. To try to develop schemes that enable efficiency and visual acuity while still maintaining the key relationship between patients and family members that we know are so critical. Next. And that leads us to the work that we've done with NEST and the Malawi Ministry of Health around the design for improving neonatal intensive care facilities in Malawi. This is a project that was specifically in collaboration with the ministry, and all of the following very beautiful graphics were developed by my student, Audrey Swanson. Next. And so in this project, as planning occurs relative to the expansion of NICUs, architectural solutions can play a crucial role in strengthening quality of care. Next. And for the implementation of this in particular, it's been a focus, as most of us know, on secondary district hospital level facilities. Next. And so not dissimilarly, we've conducted significant literature review and held numerous stakeholder engagements, and went through a frequent iteration process with stakeholders as we developed these schemes. I guess this scheme is the one we're going to show you today, with a focus on patient privacy and dignity, staff performance, infection control, daylighting and ventilation, and enduring maintenance and building performance. Next. And so in collaboration with stakeholders in the development of the program, we started to look at various organizational strategies at the facility scale. Next. And started to zoom in and identify the various levels of acuity that these facilities tend to encounter and organize the building and scheme based on that. Next. And these are organizational strategies around central courtyards and tertiary spaces that has been discussed, include opportunities for all of the sort of living landscape of health infrastructure in these settings, including cooking and laundry and dwelling, all the things that occur outside in these spaces. Next. 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 Courtyards. Courtyards are nice. So we organized this again based on levels of acuity, and interestingly, it was during this time that the notion of a high intensity or high care KMC units came into the picture as well. So we've adapted this scheme to include multiple tiers of KMC units. Next. And we really looked into each of the modules that are key to the design of such facilities: entry and reception. Next. And then the high acuity nursery space and how those spaces can be organized, again, with visual acuity from a nurse's station, but also with opportunities for multiple passageways to control infection and access from staff and patients and family members without significant overlap that we know can lead to infection issues. Next. Next. Based on a mass model from years ago, we explored a KMC unit where patients are able to look out windows and have storage access at the head of the beds to provide nooks and crannies for all of people's personal effects. Next. And overall, looking at exterior circulation strategies, access to various courtyards, and efficiencies based on program. Next. So this is the development of a prototype scheme that could be implemented at district hospitals. Obviously, there would be some variety to them based on specific contextual conditions in each facility, but the driving premise of various modules that are then connected via outdoor circulation strategies provide efficiencies for staff and patients as well. Next. And so overall, in the nursery, the programmatic scheme provides for feeding areas, maternal involvement, appropriate bed spacing scales, as well as feeding and KMC instruction and education, all organized around a central nurse's station. Next. And then obviously building performance in particular around thermal comfort and daylighting and access to power, as we know, is such a often significant issue. Next. So we've done assessments on thermal performance in the facilities, including and leading to the development of wall sections and assemblies that are appropriate and yet variable. Malawi's climate is a particularly interesting one, is that not only do you have to passively cool facilities, but you actually have to passively heat facilities in the wintertime, particularly in the higher altitude conditions. Next. And I think this is probably about the end. I think there's one more. just a couple of renderings of the facilities and campuses that give a qualitative flavor to what we're working on. And I think that does it. Yep. So we really hope that this research and design exercise can positively influence the design of NICUs across East Africa and elsewhere with similar settings. Thank you. And I may have seen in the chat, did Dr. Bundala, is Dr. Bundala still here? Dr. Bundala? Oh, donuts? Donut Shamba? Are you with us and ready to go?
Yes, so I think Dr. Bundala has unmuted himself. Dr. Bundala, can you hear us?
I will let one of you take it away.
Okay. So yeah, I will present on behalf of Dr. Bundala on neonatal unit floor plans in Tanzania, the work that we've been done in collaboration with the Ministry of Health and the NEST 360 Tanzania team. So there's several discussions to come up to this particular work that we've done, and first of all was trying to understand why do we need it and whether there is examples within the country that we can learn. But for many years and in many facilities, there were no functioning neonatal intensive care unit or specific ward for neonatal care, but rather just a neonatal corner, a place where just one within the ward that we will find a place to put newborn babies for treatment. So there was a need to come up with a plan, and as I said, so several discussions, and this was supported by Operation HESEC 1.3. So this is a strategic plan for reducing maternal and newborn health Tanzania, 1.2 and 1.3, and which also supported by HESEC Strategic Plan 5. Together aim to have at least level 2 care for newborn babies across the country. So 80% of the facility to provide level 2 care. And also the one big challenge was also the lack of data for newborn babies because they are treated everywhere. So it was very hard to track these newborn babies to know who needed what care. Next slide. And also we found that there's next. Just yeah, so there's a different understanding specifically, I mean, what we mean by neonatal care unit. So there's a different understanding, and there are those who just understood that there's a HDU, and those who understood there's just having a KMC ward or a place where you can treat sick newborn, that was enough, or with a place where you can treat newborn babies with infections. Next click. So it was very important to have a clear understanding. So we decided to have a series of meetings. We had a series of meetings with key stakeholders, and also from 2019, the Minister of Health developed a neonatal guideline. Next slide. And next slide. Yeah, neonatal guideline on your So the picture on the left, top left, which explains for the how, if you wanted to initiate a neonatal care unit, what to consider, and at least the space that you need. So we understand that there's challenges with funding, and then the government and with Dr. Bundala, who is taking lead, he's in charge of newborn unit, that to push or rather encourage that facilities or hostels should improvise on the space that they have, but if the enough funding, they can construct a completely new ward. Next slide. Next slide. Yeah, so this is an example, pictures showing that how they can improvise on the space they are available. So the picture on the top left is Dr. Bundala in one of the visits in the facilities. And then the picture on the top right, it's showing a limited space within the ward, that everything is just provided in one place. Next slide. So as part of this work, the initiative with the Ministry of Health and the NEST, then we, as we started implementing the program in Tanzania, we did an assessment in some of the facilities that we're implementing, and it was not suitable to initiate the program there. So we thought that we needed to do, as what did the government say, we were not having enough funds to construct a new neonatal ward, but rather to improvise with the existing space. So we had a space that and then we involved engineers and architects to try to give us a clear picture, using the current neonatal guideline, which is, as I said, has details on how to initiate a newborn ward, or to have a newborn ward rather. And then, so here the picture shows a Temeke Regional Referral Hospital before we did a renovation. There's Dr. Shukuru there. I see him in the list of the people who are attending the webinar today, which is great. And then the next slide will show you that after the renovation. So what we did before and what we did after. So we try to consider all the flows, so we'll ensure that there's a ward for highly infectious babies, a general ward, kangaroo mother care, and NICU for ensure that our babies who need the care are getting it. And before we did the renovation, this facility were only able to accommodate, the capacity was only 21 babies per day, but now they can, at least the capacity is up to 70 babies in one time. Next slide. So because we started that developing the floor plan just for NEST, and at the same time with the ongoing discussion with the Minister of Health, was there is another desire or demand that we should have a standardized neonatal wards at a different level of the health system. And this is starting with the regional level and the district level to ensure that all babies who need care, they get care. They need it in the right place. And another advantage was that more than 80% of mothers are delivering at the facility, and then the population is increasing. So there's a huge number of newborn babies needed in specific areas that they can be cared for, and also to help with the other ongoing initiatives, specifically the measurement of newborn, the care of the newborn babies. Yeah. Next slide. Yeah, so this is a sketchy of a neonatal ward from the district level, and so I'm sure you can't see it, but it encompasses the general ward, kangaroo mother care, isolation, and HDU, and It has a total of about 22 beds. And there are other rooms for like nursing station and changing rooms. This, doctor's office. So pressing rooms, so mothers, they can store milk and other things. All that is included. And the next slide will show you the draft of neonatal drawings at a regional level. And for this, the bed capacity is about 40 beds. So this is still ongoing work, and we hope to finalize very soon and to present it to the Chief Medical Officer and then to the Minister of Health, I still see the next slide is just to say that this is the key message that Dr. Bundala wanted to put, that because, it's still depending on the funding that most facilities don't have enough fund, but they can try to plan with what the resources they have. And for this case is to improvise the spaces they have within their facilities at the moment before getting enough funds to construct completely new one. And this actually it's linking with other work that we are also doing. As it's in part of investment case, I won't talk much about that, but just to say that part of this is also to have a clear picture or clear details on each level of care. For example, at the district level, how many health workers, for example, are needed. So including biomedical engineers or technicians, neonatal nurses or pediatrician or neonatologist. So that if the facility decided to implement that complete package, they know if, for example, the proposal is to have 4 and they only have 2, so they know they have to work to get additional 2 in different ways like they can. Yeah, thank you. This is just last slide, I think. Yeah, thank you. Dr. Bundala is still on the call, so I think he can respond some of the questions if they will come anyway. Thank you very much.
Yeah, thank you so much. I think there are some really compelling overlaps and shared issues amongst each of these endeavors that we've seen and been presented with today. I've noticed in the chat a handful of questions here. And I think one of there were several key questions around costing and financing. Would either of the panelists like to talk about how cost and financing was considered in these facilities or in these projects?
I can speak about our project quickly, and I would invite Donat to speak after that. But in our case, one of the ways that we considered how to reduce costs was as much as possible to take the facilities that we are assessing and focus on renovations as opposed to complete new constructions, complete transformations. We are trying to work within the constraints of an existing facility so that the interventions that we're proposing are sufficient to address the concerns we've identified, but using the materials that already exist, and therefore hoping to reduce time, reduce cost, reduce labor. That's one of the approaches that we've taken.
And Donat, do you have any thoughts on cost assessments?
Yeah, so this is actually within the NEST program. It is, there's a team working on that, and then so this is including how much does it cost to do a renovation at a district or regional level, and also how much does it cost to construct a completely new. So we were working with engineers and architects. They're working on developing BOQ, base of quantities, and then to include all related equipment, all equipment that is needed. So as I said, So together with the Ministry of Health, we also developed a list of all equipment that's needed at different level of the system and how much they cost. So when we give it to, let's say, to the facility or to other funders, they have a complete set. So for like, as I said, human resource, how many human resources you need. So what is the minimum package and what is the standard? And then you come to equipment. How many phototherapy do you need? How many oxygen concentrators do you need? And then when you come to what else? Just pick anything. So every item that is needed for a newborn baby. So we are quantifying that, and then we have a complete package. So let's say when we go to I'll just give an example to GFF. So we say we want you to help fund this district to construct or anything, because then you have a figure for a construction and for helping to recruit health workers, or just to donate equipment. So we haven't the cost for each. And yeah, we are happy within the team. I'm sure some of the members working on health financing are listening. And if somebody is interested, they can send an email, and we're happy to share more details on that. Thank you.
Thank you. Yeah, and in the work we did in Malawi, I think, as was commented in the chat, our assessment or our methodology was speculative and really didn't include costing outside of the logic. Let's put it this way: I've done a lot of hospitals in Malawi, so outside of kind of logical constraints, we didn't do an assessment. Rather, we were seeking to develop a relatively idealized model of what might be best for quality of care, patients, and staff. So we didn't get into the details of cost related to the project. Another question was, how do facilities undergoing renovation provide care during the time of renovation and construction? I think that's a decent one for me to provide a poor answer for, and that is it's kind of ad hoc, unfortunately, and really the design and construction phase has to take into consideration how to best optimize continuous care through the construction process. It's one of the hardest things for an architect about doing work in medical facilities is that we know they need to operate 24/7, and it makes coordination really, really challenging. But hire a good architect might be my answer to that, unfortunately. Let's see, what else?
And Chris, if I could just jump in there with our perspective, the way that we are addressing the renovation and the ongoing patient care questions, I mean, this is something that will be ultimately up to the ministries in the respective countries to determine how they want to approach this. But we are strongly encouraging them, first of all, to undertake these renovations in a phased approach, so they don't do the entire facility all at once, but rather they do space by space, so that they can continue to provide care in the untouched spaces while a certain space is being renovated. And in many cases, the facilities that we're working in, we are actually proposing shifting a service from one space to another. For example, a delivery ward is situated here, but we're proposing it be moved over here. And so in those cases, you can work on getting this delivery care space ready, but continue providing the care over here until it's ready. So that's one of the approaches that we've taken.
Yep. Agreed. Let's see, what else do we have here? There were quite a few questions. How do these designs address overcrowding? That's always a significant challenge, as we know from WHO and other standards that accommodate or recommend far too many square meters per patient relative to the realities of the context. So I think part of that is enduring use strategies of facilities. But also I think there are some design strategies that can try to isolate spaces enough that even if you're in large or overcrowded conditions, you can develop design strategies that might try to mitigate that as much as possible, or at least reduce the perception of overcrowding. There were some questions around temperature regulation, and those can be monitored typically these days in NICU facilities, particularly in the HDUs, ICUs, and high acuity spaces. That really does need to be monitored. And I think it really points to training of biomedical engineers for enduring maintenance in facilities. But that said, design strategies need to really evaluate that during the design process. Passive heating and cooling strategies are becoming more and more a key component of architectural education on the continent, and it just really needs to continue to be so. It's not terribly hard anymore to do modeling that can anticipate annual and daily temperature swings, but it is a real key factor. As we know, NICUs in particular want to be kept very warm, and it makes for rather miserable staff. So trying to get that right is a key component of the design process. Let's see. Are the designs according to levels of newborn care? There was also another related question around let's see, there was another related question as well. How do these spaces incorporate space design for immediate KMC implementation? The work we did tried to, and maybe we could go back to one of those floor plans in my section if you wanted to look at how programmatic requirements, be it type of birth or acuity and infection control strategies for isolation units, all really need to be organized around idealized settings for access to healthcare providers. So the more you can do in sort of centralized strategies where care providers have great access to all of the different various subsets are really key and important to a design process. Yet there are a couple more issues on temperature control and moisture prevention, and those are certainly factors in settings with high humidity in particular. We're seeing more and more mechanical ventilation systems, but of course those are fraught with long-term maintenance and durability considerations. So yeah, moisture prevention is a really key component, especially in high humidity contexts. I think we're about out of time here. Are we working with infection prevention in high humidity settings? I think then you want to really increase ventilation, especially passive ventilation for the particular units that don't have mechanical ventilation strategies. Keeping good cross ventilation and large overhangs for shading help to reduce humidity and moisture. But at some point, unfortunately, humidity is one that at a certain level just requires mechanical ventilation. I think that does it. We're at 9 o'clock Eastern time, and 5, 6, or 7 hours later, depending on where you are. You know, if anybody, I saw some questions that were specifically directed to me, I think, about online consultation. Please don't hesitate to reach out. You can find me if you Google Chris Harnish, Thomas Jefferson University, you'll find me. I also am part of this infrastructure unit, and I think you can find me there, or you can Google the Jefferson Health and Design Collaborative and track me down. I'd love to be further a part of any of the work that you're considering. And NEST can provide technical support for Tanzania and Africa as well. So yeah, please don't hesitate to reach out. I'm always happy to provide some insights and share my knowledge anytime I can. I think that does it. The next HSBB seminar will be on medical supplies and devices on November 1st. Please keep monitoring our websites, and we hope to see you at that one as well. Is that it, or any closing remarks from our leadership team?
Just want to say thank you all very much for allowing us to present here. It's been an honor.
Yeah, you're welcome. Thank you. Thanks to all of our panelists and everyone who participated today. Really thoughtful insights, and I enjoyed it.